Welcome to It's Your Case, presented by vetct.com. I'm Christina Meerhof, your radiologist on demand for this week. Today's example is a 9-year-old female spayed medium-sized crossbreed with diarrhea, vomiting, and hyperexia. Once you have reviewed the radiographs using your systematic approach, then you're ready to watch this video. Now I will highlight the most important findings for these radiographs. We will start with the skeletal structures. There are incompletely bridging spondylosis present in the caudal thoracic, the lumbar spine, and at the lumbosacral transition. The lumbosacral intervertebral disc space is difficult to delineate, probably due to new bone formation and also rotation of the pelvis. So you see that the iliac wings are rotated against each other. The diaphysis of one femur is widened, and the cortex cannot be followed completely. It's really thin or not present here on this level. We do not see any fracture lines, and these areas are bridged by smoothly delineated new bone formation. You can have a look at this femur in the other projection. It looks more or less the same, so there's bridging new bone formation, but the cortex has not reformed until now. A metal-opaque, perfectly round structure superimposed with the retroperitoneal space, ventral to L2-3, also visible here to the left of the spine. And the detail in the retroperitoneal space is normal. The liver can be delineated in the left lateral projection. It does not extend over the caudal rib cage. The splenic tail is visible here, caudal to the liver. It's a bit more difficult to see due to superimposed skin folds on the right lateral projection. And I see the splenic head here, and the spleen is also in this view mildly enlarged. The kidneys have a normal size and shape. I can see the left kidney here, and the right kidney here. And the urinary bladder is mildly filled. The stomach is moderately filled with granular material and gas. I see granular material here. And in the VD view, there's granular material in the fundus and gas in the region of the antrum. The gastric axis is normal, it's more or less parallel to the ribs. The descending duodenum contains a moderate amount of gas and has a straight course. The gastroduodenal angle is widened. And the duodenum is displaced laterally. The serosal detail is reduced in the right cranial abdomen. So if we follow the gastric contour, it can be nicely delineated here, and then it becomes blurry. And although the stomach contains some gas in this region, I cannot delineate the wall properly. And also the intestines in this region are really difficult to delineate. So there's a focal loss of serosal detail in the right cranial abdomen. Other small intestinal loops contain small to moderate amounts of gas. There are signs of peristalsis, and the colon contains a rather small amount of granular material and some gas. So I see the descending colon here, transverse colon, and then I lose it, and then on the lateral projection there's some material here in the descending colon, some gas, and then I lose it. This could very well be cecum, and it looks more or less the same in the left lateral projection. I lose the colon somewhere here. So my conclusions are we have indirect signs for pancreatitis with a focal loss of serosal detail, We have a mild splenomegaly. We have signs for chronic intervertebral disc disease at the lumbosacral transition. There's this chronic fracture of the femur, which is an incidental finding, the projectile in the retroperitoneal space, and spondyloarthropathy in the thoracic and lumbar spine. So my comments for this case are the following. The focally reduced abdominal detail, the widened gastroduodenal angle, and the displacement of the descending duodenum are indirect signs for a pancreatitis. This could be potentially associated also with duodenitis and gastritis, and I would recommend to do CPLI and an ultrasound of the abdomen to confirm a pancreatitis. The mild splenomegaly is unspecific. It could be caused by congestion, storage, extramedullary hematopoiesis, and less likely as splenitis or diffuse neoplasia. In case ultrasound is performed, the spleen should also be evaluated to exclude possible parenchyma changes. The projectile is not associated with any soft tissue changes or reduced abdominal details, so it's also considered an incidental finding, and the position of the projectile could be determined also during abdominal ultrasound. The significance of the lumbosacral findings have to be evaluated clinically, and the fracture is healed, but the cortex did not finally reform, which will probably happen within the next weeks. Be sure to review the full report associated with this case. Thanks for listening, and remember, it's your case, so please post your questions on social media.